Hello, everyone. I hope you're all doing well. I'm so sorry for the technical difficulties we had earlier, but we're glad to start now. Welcome to the fifth week of our teaching series. My name is Rashida, person at SUPTA. This week, we are focusing on vascular surgery, and we're very happy to have you all here with us. Today, I am joined by Sohib, who will guide you through acute limb ischemia. Just to introduce Sohib, he is a third year from Hull York University. To make this session as engaging as possible, we'll be releasing polls throughout. These are completely anonymous, so we encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll address them at the end of the session. We'll also share a feedback form at the end. If you complete this, you will receive a certificate and exclusive discount codes for Teach Me Surgery and Pass the MRCS. This session is being recorded. The recording and the slides will be shared on our Metal page as well as our website a couple of hours after the session, so be sure to keep an eye out for that. As you may know, we have launched our very own learning portal, which is hosted on our website. Through this portal, you'll get access to practice questions, session recordings, and revision material. As a bonus, all members will get a discount code to 10% off Geeky Medics, anatomy flashcards, surgical flashcards, and knowledge bundle. Membership is completely free, so be sure to head on to our website after the session to explore this. We also have an exciting opportunity for our attendees. Two people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the unique code we will provide. The more sessions you attend live, the higher your chances of winning. So be sure to stay until the end of the session and attend as many of our other sessions as well. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. Without further ado, I'll now hand it over to Sohib.
Right. Okay. Good evening, everyone. My name is, just to introduce myself, my name is Suhaib, and I'm a third-year medical student. And today I'm going to give a presentation about acute limb ischemia. So let's get started. So just to re-thank our partners who made the session possible today. Right. So here are the learning objectives. Please don't get frightened. I know there's a lot of them. You don't need to read them or anything. It's just kind of something that you can go back to so you know what the presentation is talking about. And I'll break everything down for you. Okay. So if we can start with an overview. So in terms of the definition of acute limb ischemia, so I've written it's a sudden reduction in blood flow to a limb, and it leading to a potential tissue damage and necrosis, and it's a vascular emergency, and it requires urgent diagnosis and intervention. So kind of I bolded out the keywords here that I think are quite important. So the first one, it's sudden. So the symptoms and the signs, they come quite quickly, with the most prominent one being pain, and we're going to talk about all the clinical presentation and everything. It comes quite quickly, and that's obviously already you can distinguish acute limb ischemia from other differential diagnoses that we're going to speak about. The reason why I bolded up, it doesn't have to lead to necrosis. It doesn't have to lead to limb amputation. We could save it, and so the biggest thing I'm going to be mentioning about acute limb ischemia throughout the session is how critical time is with acute limb ischemia. So that's diagnosing it and then start the treatment straight away. The reason why I said emergency, again, just to reiterate that it's time-linked condition, and we need to have urgent diagnosis and intervention. Just to make sure people know what acute limb ischemia is, because this is the skeleton of everything I'm going to speak about today. We can imagine the body like a big city, and all the different roads in the city are like the arteries. And so you need obviously the roads to deliver food and to deliver wherever has to be delivered throughout the city. And we can imagine the outskirts of the cities as being the four limbs of the body, obviously the two arms and the two legs. And so if you get a really big traffic jam in this road, the cause, which represent the blood, can't go beyond the traffic jam. And so the traffic jam represents a blood clot or something that blocks the artery. And so wherever is beyond the artery, down the legs or across the arms, it's not going to get what's needed, i.e. oxygen, which then could lead to necrosis and tissue damage. And so obviously it could potentially lead to that if it's prolonged. Obviously, time is critical, as I've mentioned. So in terms of the causes, the two that I've mentioned here is embolism and thrombosis. Embolism is obviously it's when a blood clot travels from somewhere else in the body to another artery and then blocks the artery. So the biggest example I can think of is obviously atrial fibrillation. As we all know, it could lead to strokes, or it could lead to PE. It depends what side of the heart the blood clot has formed. So obviously the blood clot could be formed. It could go out of the heart and then could go block one of the arteries that supply one of the limbs. And then thrombosis could happen. And just to say what thrombosis is, it's just a clot that happens within the artery, and it usually happens in an artery that has a pre-existing atherosclerosis. So atherosclerosis is just hardening of the arteries. So already just from the causes, you can kind of guess some risk factors for acute limb ischemia. So like you can just say arrhythmias like atrial fibrillation, that's a risk factor. You could say age. Age is the biggest risk factor for atherosclerosis, and from atherosclerosis, thrombosis could happen, which could then lead to acute limb ischemia. You could say things like diabetes. You could say things like hypertension. All these things could lead to atherosclerosis, and so logically, it's a risk factor for acute limb ischemia. So obviously, in terms of the clinical importance, untreated acute limb ischemia, as I said, could lead to necrosis, which could then lead to gangrene, which could then lead to limb loss. It could also lead to death. So obviously, death is death. In terms of limb loss, that would obviously require an amputation, which is something that we try to avoid. That's the biggest thing what we're trying to avoid with acute limb ischemia. And so delayed treatment, as I've mentioned, it increases the irreversible damage that could happen. And so just to make it quite clear, just every hour counts with acute limb ischemia. In terms of mortality, it could be as high as 20-25%. As you can see here, every time I say some sort of complication or clinical importance, I always say that's without an early intervention or without prompt treatment. And so just to reiterate, that time is very critical with acute limb ischemia, and it could be treated and managed quite quickly, and no post-complication could happen. So can we write in the chat what are the main pulses to be felt in the lower limb? Oh, I pressed it quite. Sorry. Okay. So there's 4 of them, and pulse in the lower limb that could be felt. Okay. Yeah. Okay. So 2 people said femoral. So we can say femoral. Now we can go down. Yep. We go down to popliteal, and then we go down even further. It will be dorsalis pedis. Very good. And posterior tibial. Very good. So obviously the reason why I'm mentioning those is I'm just going to try to go back to the anatomy of all the arteries in the lower limb. And yeah, thank you very much for your responses. So I'll just try to go back to the anatomy, and then hopefully you'll understand why things happen in a certain way. And I just want everyone to be on the same kind of baseline before I go a bit advanced. So there is 4 pulses the main 4 pulses that you could feel for. So we saw the femoral pulse. Generally, it's located in the groin area, and people always describe it as it's midway between the anterior superior iliac spine and the pubic symphysis. And so the anterior superior iliac spine is, you can kind of feel it in yourself. If you just go to one of your hips, just very superior to your femur, and if you kind of just deeply palpate it, you can feel the anterior superior iliac spine. It's around here, if you can see my mouse. And so this is the first landmark, and then the second landmark is the pubic symphysis, which connects the 2 hip bones. And then somewhere in between of them, that's where you feel the femoral pulse. Sometimes it's a bit deep, so you have to be pressing a little bit deeply. Just before I move on to the other ones, this is just some sort of an idea where the pulses are. It differs from a person to person. So this is kind of a guidance to where to start, and then you can move on around the area, and then you'll find the pulse. And then next on the list, if you just go inferiorly, so now with the femoral artery, we're going down to the popliteal artery. So there's a popliteal pulse. The word popliteal in anatomy just means the knee. And so it's the popliteal artery, it's found on the back, so posteriorly, you feel it posteriorly, and it's behind the knee in a place called the popliteal fossa and the popliteal triangle, which has its own boundaries and content and clinical significance that I'm not going to get into. But one thing to mention about popliteal pulse is that it's quite deep as well, and you need to kind of press firmly behind the knee to feel for it. So obviously warn the patient about this. So this is the popliteal artery, and then if you go even further down, we'll have the posterior tibial pulse. Obviously, by the way, later on I'm going to discuss how they branch from each other and everything, and it will all make sense. So just trust me on this one. So for posterior tibial pulse, it's palpated just behind the medial malleus of the tibia. So the medial malleus is just a bony-like structure, a prominent bony-like structure on the inside of your ankle. So this is the medial malleus, and then just behind it, just posterior to it, as you can see in the picture, this is where you feel for the pulse of the posterior tibial artery. And then if we go more on the dorsum of the foot, just means the top of the foot, just to make things simple, this is the dorsalis pedis artery. The dorsalis pedis pulse. The dorsalis just is coming from the word dorsum of the foot, so you already know it's in the top of the foot. Pedis just it means foot, so it makes sense why it's called this way. And it's lateral to the extensor hallucis longus. So let's make this very quiet. It's not that hard. So extensor hallucis longus is just the tendon of the muscle that extend the big toe. And so if you just look at the big toe of the patient and then you extend the big toe as if and lift it up a little bit, you will be seeing the tendon of the muscle. It's quite big. So this is a very good idea to just try to feel for it. And you know, this is the tendon, you know where you're at now. And then just a bit lateral to it, this is where the dorsalis pedis pulse should be felt. Obviously, as I said, it differs a little bit from a patient to patient. Just another question. Which finger should I not be using to feel for these pulses? If you can just write in the chat. So just say the question again. Which finger should I not be using to feel for the pulses? Smallest. I need let's be more specific. So which one is the smallest? Okay, interesting. I'm getting quite different answers. I'll just wait a little bit longer. I want to see what other people think. Doesn't matter if it's wrong. I just need a. Yeah, it's the thumb. Very good. I'm also quite surprised that people who are not in clinicalese as well, they already know this. So the reason why you can't use the pulse to feel, use your thumb to feel for the pulse is because you could feel your own pulse of your thumb. And so obviously that you can already imagine how misleading and how much it could lead to just artifacts and things that findings that shouldn't be there, and it's there just because you're feeling your own pulse rather than the patient's pulse. Very good. Okay, just trust me on this one. It would get a little bit boring just naturally because anatomy is quite hard to teach, but it will make sense everything why I'm saying things in a certain way. So let's just go through structure by structure and everything will make sense, hopefully. So the first one is a great saphenous vein. So as you can see here in the left picture, the great saphenous vein drains into the common femoral vein. And so just to kind of, if I want to describe it, in a fancy anatomical way, it just ascends down the medial side superiorly, and then it feeds into the femoral vein. So this is how you would describe it. It's quite clinically important. I mean, the first thing that I could think of, sometimes it's used in CABG, so coronary artery bypass graft. For things like in the heart and stuff. See, that's a different topic, but it is very clinically important. It's a huge vein as well that runs down across the entire leg in the medial side. So moving on, now we're talking about the fascia lata. That's the way I say it. So obviously it's located in the lateral side of your upper thigh, and one of its main purposes is that it contains and support all the muscles in the area, and it contains them in a way so that all the veins that are located in the muscles, they could be squeezed every time the muscle get contracted. So every time the muscle contracts, the veins get squeezed, and so the blood will go up. Obviously, especially in the lower limb, the blood when it goes back to the heart, it goes against gravity. So it needs some sort of assistance, and it can't just rely on diastolic blood pressure to go back to the heart. And so one of its ways that it could help is the muscle contraction that is assisted by the fascia lata. So that obviously helps with venous return. In terms of the third structure is the iliotibial tract. So this is just a continuation of the tensor fascia lata. It's just a continuation of it, and it inserts into the lateral side of the knee. I mean, I think the fancy word for it is just the iliac crest of the tibia. But just to make things easier for you, it just inserts on the lateral side of the knee. And so you could already imagine that it gives some kind of stabilization to the knee, and it would be more of a lateral stabilization, and it happens generally more when the muscle is contracting. In terms of the femoral sheath, so the femoral sheath is continuation of the abdominal fascia. So obviously there's a lot of fascia in the abdomen. One of them continues down past a certain structure that I'm going to speak about later. I don't want to ruin it now. It goes down and then it forms into the femoral sheath. So the femoral sheath contains, as you can see in the picture, it contains the femoral vein and the femoral artery. It does not contain the femoral nerve. That could come up in the exam. So just be aware of that, because it's a bit tricky, because the femoral sheath is different to the femoral triangle. The femoral triangle is just the entire triangle, which I'm going to speak about. So you can praise yourself up with that. But in terms of the femoral sheath, it just contains the artery and the vein. And yeah, so it kind of encloses the artery and the vein. And so obviously for surgeons, that's something you have to be aware of. So if we can just go, so now I'm just going for a pull. I'm just waiting for the pull to pop up, I think. So Rashita, can you just put the pull up for me? Okay, interesting. Can you guys see the pull? I'm not really sure. Oh, actually, right. Can you guys see it now? Can just somebody say yes? Yep, I think you guys can see it. Okay, thank you. So which artery is the main artery supplying the lower limb? Okay. So majority people went for femoral artery. And that is indeed the correct answer. So the femoral artery is the main artery that supplies the, is the main artery that supplies the lower limb. And so I just need to talk about the way it comes about and becomes the femoral artery. And so if you just look in this picture, so the one is all the way down, obviously you can see the descending aorta. The descending aorta, once it crosses the diaphragm, it becomes the abdominal aorta. And then the abdominal aorta eventually bifurcates into the common iliac arteries. And then the common iliac artery, if you look at an individual common iliac artery, it becomes the internal and the external iliac artery. And so now I need to go back to the first picture, this one. And this is the external iliac artery. And so once it crosses a certain structure, it becomes the femoral artery. Can somebody tell me what this ligament is? So this is the ligament in which when the external iliac artery crosses, it becomes the femoral artery. So it's a ligament, if you guys remember, just for a hint. Very good. It's the inguinal ligament. So the inguinal ligament goes from the anterior superior iliac spine to the, yeah, very good, inguinal ligament, to the pubic tubercle, which is just right next to the pubic symphysis. The inguinal ligament is hugely important. It's if one thing you want to remember from all these, a lot of in the pelvis, this is the one that you should know just one. It's a landmark for so many things like hernias and femoral triangle, and obviously here as well, the external iliac artery becoming the femoral artery. So just be aware of it. In terms of the pathway, it travels, in terms of the femoral artery pathway, it travels through the thigh, And then once it crosses from the back, once it crosses and gets into the popliteal fossa, just behind the knee, it becomes the popliteal artery. So the popliteal artery is just a continuation of the femoral artery. Just don't overcomplicate it. It's just it's named differently because now it's in a different location and it crossed a certain anatomical landmark. So obviously the femoral artery is hugely significant because it is what supplies the oxygenated blood to the lower limb, and it's obviously essential for the entire circulation of the thigh, knee, and leg. Okay, move on to the other one. So which structure is not found in the femoral triangle? Okay, I kind of ruined it. I keep pressing the oh, that's fine. I keep pressing the slides and I don't realize it goes to the next slide. Okay, very good. Yeah, so the structure that is not found in the femoral triangle is the common peroneal nerve. So the common peroneal nerve, it's a branch of the sciatic nerve, and it's located in the posterior thigh and the lower leg. So it's kind of the opposite side. Obviously, now we're talking about the anterior side because that's where the femoral artery kind of goes into. The common peroneal nerve is completely different. And we're going to see now what's actually included in the femoral triangle. So now we're talking about the femoral triangle. So in terms of where the location is, I just tried to make it as simple as possible. It's just situated in the upper thigh. As you can see here, you can kind of see the three lines that make the triangle. So I've intentionally obviously blurred out the three boundaries or the three borders of the femoral triangle. So can somebody tell me what's the superior border? So this one. Yeah, very good. Thank you for participating. So this is one that I've mentioned. This is the inguinal ligament. So that's the second time now, just in 2 slides, you see how significant inguinal ligament is. So it's the superior border of the femoral triangle. What about the lateral border? So this one, which is a muscle. Somebody, very good. Sartorius muscle. So the sartorius muscle, just a fun fact, is the tallest muscle in the human body. And it's quite interesting once you look at it in real life. It runs from the anterior superior iliac spine. So it has the same origin as the inguinal ligament. And it runs and kind of goes to the medial side of the knee. So it runs across the entire thigh inferiorly and then kind of rotates around the thigh and insert on the lateral side. So it starts on the medial side of the knee. Sorry. So it starts on the lateral side in anterior superior iliac spine, and then it kind of goes its way around until it goes to the medial side of the knee. So it's quite long. Hence, it's the longest one in the human body. So what's the medial border, which is also a muscle? Very good. It's the adductor longus muscle. Adductor longus muscle alongside the adductor brevis and the adductor magnus, 3 adductor muscles in the medial compartment of the thigh, and it just helps adducting the thigh, so just bringing the 2 thighs back together. So why is it important? Another kind of importance other than its function is that it's the medial border of the femoral triangle. In terms of the content, which is probably what you're most interested in, so it has the femoral artery, vein, and nerve, and there is a good mnemonic used to remember the femoral triangle the femoral triangle content, which is called navel. So navel, it's quite easy to remember, and it just stands for navel, N for nerve, A for artery, V for vein, E for space, which refers to the femoral canal, and then L for lymphatics. So obviously, the only thing you just need to remember that we're talking about from lateral to medial, because if you think in your head it's from medial to lateral, you're gonna get everything else, everything the other way around. So we're talking from lateral to medial, okay? And it's navel, nerve, as you can see here, nerve, artery, vein, and then the femoral canal, which is the empty space, and then the lymphatics would be somewhere around here. Very good. Obviously, as I said, the femoral triangle is very significant for things like femoral hernia, which is quite an interesting hernia. It has a high risk of strangulation, I think, and so it does require surgery to fix. And so femoral triangle is something that you definitely need to know from your preclinical side of stuff to the clinic, and you're always going to see in the hospital, and you're always going to get quiz about it as well from the surgeons. Okay, So now we can see that I've mentioned the pulses, and now I've spoken about the femoral artery, the femoral triangle that the femoral artery goes through, and now we're gonna go down. So inferiorly now, we're gonna talk about the popliteal artery. Trust me on this one, guys. This is the last slide about the anatomy. It's just I need to know everything. You guys need to understand all these kind of stuff to understand acute limb ischemia. So now we've moved inferiorly. Now we're talking about the popliteal artery and also the arterial supply of the foot. I'll put everything in one slide just to make it quite quick. So the popliteal artery now is gonna go posteriorly and comes out from the back of the knee. So just so that we know what we're looking at here, the picture on the left, this is a right leg, and we're looking at it from the posterior view, from the back. Okay. So you can see now the popliteal artery. It's just, as I said, it's just a continuation of the femoral artery, and it passes through the popliteal fossa. And it goes down. It goes down. Obviously, it supplies the knee structures. And then it goes down and it goes down, it goes down, and it gives the first branch, the anterior tibial artery. So the anterior tibial artery, obviously, is called the anterior. So it doesn't make sense for the artery to stay in the posterior view. It shouldn't be here. This is not where it belongs. And so you can understand now that the anterior tibial artery will go from the back, goes through the muscles anteriorly, and then it pops out from the other side. So now if we look at the picture on the right, it pops out from the other side, and now it's the anterior tibial artery supplying the anterior side of the anterior, the muscles in this compartment in the anterior leg, lower leg. And so this is just the anterior tibial artery right there. Here we go, and it goes down, it goes down, it goes down, it goes down, and boom. That was called the dorsalis pedis artery. So now you know that the dorsalis pedis artery is a branch of the anterior tibial artery. It has to be. It can't be branched from the posterior, because the dorsalis pedis artery, it's in the dorsum of the pedis, the dorsum, the top of the foot. And so it has to be from the anterior side. So it has to be a branch from some kind of an anterior artery. And so the anterior artery that gives a branch of it is the anterior tibial artery. Okay, just a little side note. It becomes the dorsalis pedis artery once it crosses this structure right here, which I think is called the extensor retiniculum. Sorry, this is year 2 stuff, and not everything is in my head. Yeah, it's called because I think there's an inferior one. I think this one's called the superior extensor retiniculum, and then once it crosses it, it becomes a dorsalis pedis artery. Now, if you guys remember what I said about the extensor hallucis longus, this tendon right there, now you can see it. So it inserts in the most distal part of the big toe, and then if you just follow along, it's just a muscle. So this is the muscle that's called the extensor hallucis longus. It extends the big toe, it makes it go up, and right lateral to it is the dorsalis pedis artery. So it makes sense. This is where you would feel for the pulse of the dorsalis pedis pulse. Okay, very good. Now we're going to go back to the first picture. So we've said the popliteal artery, it goes down, and then it gives the first branch of the anterior tibial artery. Because it's anterior, it can't stay here. It has to go through the muscle, pops out from the other side, from the anterior view. Okay, now we're going to go down. Because there is one that's called anterior, you can kind of imagine there's one that's called the posterior. So the second artery, the second branch of the popliteal artery is the posterior tibial artery. So the posterior tibial artery, as you can see, it keeps going. It stays on that side because it has to be posterior, since the name. That's why it's called this way. And it goes all the way down, all the way down, all the way down, all the way down. And now we can see it's right posteriorly to the medial malleus of the tibia. So this is the medial malleus, this one. And it's right posterior to it. This is where the artery runs. And so it makes sense where this is where you would feel for the pulse. It gives branches out like the medial and lateral plantar arteries or something, and it's, well, I'm not gonna say it's irrelevant, but it's just quite irrelevant to this side of things, the acute limb ischemia side of things, because you wouldn't really feel for anything. These arteries, you wouldn't really feel for them. You would feel for the posterior tibial artery. Okay, third one is the fibular artery. And the fibular artery is another name for it is the peroneal artery. I like to remember it as the fibular artery because it does kind of make sense to me, since there's 2 bones anyway, the tibia, which is on the medial side, and then the fibula, which is on the lateral side. It makes sense to just have it called the fibular artery, but just be aware of the peroneal artery, because as like the name, they're exchangeable, they're the exact same thing, just in case in the exam they decide to use the peroneal artery instead, the word peroneal. So one thing, peroneal artery. So the fibular artery. So basically, what happened? The fibula said, "Okay, Tibia, now you have 2 arteries for yourselves. You have 2 arteries that are named after you. I know I'm a smaller bone. I'm the younger brother, but I still need an artery myself. I deserve one. The popliteal artery, which is the dad, he's too stingy. He doesn't want to give any branches to the fibular artery. So what happened? It was the posterior tibial artery that gave branch to the fibular artery. So the fibular artery is not technically a straight up branch from the popliteal artery. I mean, it kind of is, because eventually it goes up and becomes a popliteal artery. That makes sense. But it's not actually the popliteal artery that gives a branch artery. It's the posterior tibial artery. It's the big brother giving the small brother, the tibia giving the fibula an artery. Because it felt bad for him. This is the way I remembered it. And so the fibular artery is a branch of the posterior tibial artery. Right. And then it runs this way. It just, it supplies, you don't really feel a pulse for it or anything, clinically at least. It runs on the lateral side. As you can imagine, it supplies the lateral compartment of the leg. I don't remember the muscles really. I think it's quite relevant for this session, but I know it everts the foot. So the foot is here. It just makes it like this. It everts it. The reason why it's very important to know that what's branches of what is because you need to know, when you feel for the pulses, the reason why you need to feel for acute limb ischemia, you need to know where the occlusion is. You need to know where the blockage is. So if you could feel something in the femoral artery, you could feel the pulse, but you can't pulse for the popliteal artery. That means that the blockage is somewhere between the femoral and the popliteal. It has to be. It can't be before the femoral, because you could feel the femoral, but then you can't feel the popliteal. So it has to be just somewhere in the femoral artery, down a little bit inferiorly. It has to be somewhere here because you can't feel the popliteal. It gets a tiny bit more complex when you go down to these ones. That's why I spend a bit of time explaining them. Because if you can't feel the anterior tibial artery, right? That if you can't feel if you can't feel the pulse for the anterior tibial artery, that means the sorry, I'm getting things confused. If you can't feel the pulse for the popliteal artery, it makes sense. Everything else you can't feel the pulse for, because everything is ultimately a branch of the popliteal artery. So just be aware of it, because it is clinically important and it could come up in the exams especially for year 1 and year 2s. Other thing why these lower pulses, the pulses of the foot, what we call the pulses of the foot, the posterior tibial artery and the dorsalis pedis artery, is because you do it for things like diabetic foot examination. So it does pop up in some different aspects of medicine, not just vascular surgery. Right. Okay. So now I want to say the boring part is out of the way. Now I'm going to speak clinical and talk about acute limb ischemia. Okay. So I think it's loading. Here we go. So what is the most common cause of acute limb ischemia? Let me just, there we go. There you go. So we've mentioned embolism, we've mentioned thrombosis, there's other two as well, but which one is the most common? Sorry. Interesting. Yeah, I kind of imagine that this one will be a good split, because I intentionally didn't mention which one is more common. Okay. 7 responses. So that means I think 5 people went for thrombosis, 2 people went for embolism. Okay. Right. I wonder which one it is. Yep. I'm sorry about that. It's the embolism one. It's not thrombosis. So obviously both of them are a very common cause of acute limb ischemia. Obviously, as I said, embolism is usually from a cardiac cause like atrial fibrillation, and it then causes the suddenly blocks the blood flow from an artery. Thrombosis is more common when it happens from a chronic limb ischemia. Chronic limb ischemia is something that's quite different, even though it has the same name. So it's different because of the onset. So in chronic limb ischemia, that could then lead to acute limb ischemia. So kind of a gradual occlusion of the artery, and then becomes blocked out of nowhere. This is when thrombosis comes in. This is when thrombosis is more common. And I know the risk factors for thrombosis, if I can think of them, is more than there's a lot more risk factors for thrombosis than embolism. But if we're talking statistically, embolism is the most common cause. And the most common cause of embolism is atrial fibrillation. In terms of trauma and aneurysm, they are also causes of acute limb ischemia, by the way, but they're just a lot less common. But they could cause acute limb ischemia. Right. Okay. Now we're going to be serious. So now we're talking about the clinical presentation of acute limb ischemia. It's probably the most important slide in this entire PowerPoint. As little information as is written, it's because, as I've mentioned before, acute limb ischemia is quite, all you think about is time. All you need to think about is how you can diagnose it as quickly as possible and then treat it as quickly as possible. And so you need to be very aware of the 6 Ps. It's quite convenient that they all start with the same letter. That's a good way of remembering it anyway. The picture on the right, I just got it from Teach Me Surgery, which you go through the 6 Ps quite well. And I've put the 6 Ps in this order because the first 3 are the most common initial features. Just to point out, because this is a misconception that I had before, not all of them have to be present to make it acute limb ischemia. Acute limb ischemia could technically just come with pain. Very quickly, though, it will become pulselessness because it makes sense because the occlusion, the artery will be occluded, so you won't feel for the pulse. Very quickly, it will become pale because you're not getting any oxygen supply to the place. And then when it gets a little bit more advanced, somehow you're not picking it up, or the patient hasn't came to the emergency department yet. Then paresthesia could happen. It could become piercingly cold, eventually, this is the latest one, is the paralysis. So in terms of the pain, just to describe it, it's a sudden. This is what I mentioned at the beginning. It's a sudden pain. If it's something that is gradual and has been happening over 4 to 5, 6 months, you probably, it's not probably the typical acute limb ischemia. It could be acute limb ischemia coming from chronic limb ischemia, but this is something a little bit more advanced. So just to make it quite simple, it's pain that is quite sudden and it's very severe. So the patient will be describing as it depends on the patient, obviously, but the patient will be describing as a 7, 8 plus out of 10 kind of pain. Obviously, pallor, it becomes pale because of the reduced blood flow. This is quite simple. Pulselessness, this is one that I've been talking about, I think, since the beginning. There will be no pulse in the artery that is affected. And another thing to point out, the capillary refill could be slowed as well. This is another thing. So you could feel for the capillary refill. Obviously, you could just squeeze one of the fingers for a few seconds and then let it go. And then you're just assessing for the reperfusion. And so you want to see how quickly it becomes red again. And the normal is less than 2 seconds. So this is the capillary refill, which might be delayed or even absent. So if it's quite severe, it will be absent. In terms of paresthesia, the way the patient will describe it, because this is very important to know how we say it, how medical professionals, how we say it, but then how patients describe it as well, because you need to pick up from their history. That's why history is the biggest weapon the doctor could have. So they will probably be referring it to as pins and needles. This is the way they will be referring it to. Obviously, they're going to talk about the affected limb. Let's say in this picture is the left limb, lower limb. So they're going to be like, oh, I feel pins and needles in this limb, doctor. Personally cold. It's in the name. It feels cold, so it feels cold to the patient and to yourself too. So the patient could say that the right leg is quite cold, and then when you feel it with the back of your hand, it's very cold. So this is the 5th feature. As I said, not all of them have to be present. And I guess it's a bit bad. It's a bit of a bad news if all of them are present, even though I guess it'd be easier for you to be like, oh, that's acute limb ischemia. That's the 6 Ps right there. It's quite bad news because that means it got quite advanced and you're a little bit late into diagnosing it. But the paralysis is in the name. It's just a loss of motor function, and it happens when even the nerves get damaged. So that's how severe it becomes. Okay, so now we've talked about the clinical presentation, how we're going to see acute limb ischemia in the hospital. You can't always think acute limb ischemia. There is some stuff that could mimic acute limb ischemia or quite similar in presentation. There will obviously be a few differences, but there you have to think about them. So can you guys tell me, it's quite difficult, especially for preclinical students. Can you tell me any kind of differential diagnosis you could think? So this is diagnoses that you have to make sure, you have to exclude them before saying, okay, this is acute limb ischemia. So there's few of them. They don't have to be exact same presentation. They just could be a bit similar, but obviously there would be a few differences in terms of the history differences. So could anybody think of anything for differential diagnosis of acute limb ischemia? Anyone? Okay, that's fine. I think I'll give it just 10 more seconds. But it is a tough question just to know out of the spot, to be honest. I only know it because it's, I did my pre-reading on it. Okay, that's fine. So these are the four. Yeah, the four that I've thought of. There will be more, right? It depends on the history. It depends on things like the risk factors. It depends on if it happened before or not. It depends on a lot of things. But the four conditions, the four conditions that I was thinking of is peripheral vascular disease, which I think you guys had a session about it last evening. So peripheral vascular disease, the biggest distinction from acute limb ischemia that has more of a gradual onset of chronic claudication. So the patient will feel a little pain in one of the limbs, maybe both of them. Depends how bad the peripheral vascular disease is. But let's say it's affecting one of the limbs, they will feel a little bit of pain, especially when they do some sort of movements like walking. But the pain tends to be quite gradual. Whereas as acute limb ischemia, as I've mentioned before, it's very sudden and it's a little bit more severe than peripheral vascular diseases. Obviously, being a little bit more severe, that's not really the biggest distinction. The biggest distinction is how sudden the onset of pain is compared to peripheral vascular diseases. Right, compartment syndrome. Compartment syndrome is I actually seen in the GP before. It could occurs after it could happen after trauma or compression. Majority of the time, it happens after that. It happens when a patient breaks one of the bones, in the lower limb, like the tibia or something, and then after the surgery, there is just a constant pain there. I think one of the biggest things, especially in the exam, that kind of tells you, okay, this is compartment syndrome, is when they say that the pain is disproportionate to how the injury actually looks. It feels like the patient is over exaggerating the pain. This is when kind of you think, okay, maybe it's compartment syndrome, especially if you take a good history and they had a broken bone recently or something. But one of the biggest distinction again from acute limb ischemia is the same fact that the acute limb ischemia is acute, and so the pain becomes quite sudden. DVT is another interesting one that I wanted to mention. We don't always think arteries. Peripheral vascular disease is arteries. Compartment syndrome happens mainly because of an artery having something wrong with an artery, or initially something wrong with an artery. DVT is a vein. So this is something you really don't want to miss. You really don't want to miss. DVT could lead to PE, which just simply could kill the patient. And so, the fact that they have pain, you don't want to jump into acute limb ischemia straight away, even though acute limb ischemia is quite dangerous and you need to absolutely make sure it's not acute limb ischemia. But DVT is just as dangerous. And so it leads, majority of the time, it leads to swelling and redness. And it should be, theoretically, it should be just in one of the legs. So it's a unilateral. It's a unilateral redness and swelling. It's around the calf majority of the time. And whereas with acute limb ischemia, you don't really get swelling or anything like that. It's more of it's just painful and it becomes cold. So this is the first thing. The DVT as well, the calf should be quite warm. This is how they describe it. Whereas with acute limb ischemia, it's quite cold. Another thing is just the color of the skin around it. It will be a little bit reddish with the DVT, but it will be a little bit whitish, more pale with acute limb ischemia. The last one that I've mentioned was Raynaud's phenomenon, which is an interesting one. It's when there is small arteries in the digits, so just in the fingers, and they become occluded because of a certain environmental factor. The most prominent factor is being very cold, so being very cold outside. The affected fingers becomes a bit pale. It becomes a bit painful, and they have quite a similar acute limb ischemia kind of presentation. But the biggest thing is that Raynaud's phenomenon does only, not only, but majority of the time affects the small arteries, whereas acute limb large arteries. And so you could already imagine acute limb ischemia is it's a biggest thing compared to Raynaud's phenomenon. Right. So now we've thought about differential diagnosis. We could already exclude a lot of the differential diagnosis just from taking a really good history from the patient. Now, one of the big things as well is investigations. Before I move on to these investigations, which I'm going to break down for you, it's important to know that a lot of doctors make the clinical diagnosis of acute limb ischemia before doing any investigation, because I said that time is quite critical. Obviously, with experience and stuff, and taking a good history, you could already be quite certain, okay, this is probably acute limb ischemia, so let's start treating it, and then we could later confirm that it's actually acute limb ischemia. I mean, it makes sense, because maybe waiting for all these investigations will be too late, and the patient will have to have their limb amputated. So with majority of the conditions, the way you investigate for them is you go from the least invasive to the most invasive, kind of from more bedside kind of investigation to more of imaging and whatnot. So this is no different. Obviously, as I said, you sometimes make the diagnosis based on clinical diagnosis and that's it. But kind of for us to do it systematically, I want to also mention all of this. So in terms of the FBC, you don't just do the FBC for the sake of it. I know FBC, every patient in the hospital has an FBC taken from them. But I just, if the doctor asks you, why would you do an FBC, you can't really say just because I did mention in the ward round before, you just do it just because. And that's really not really the case. You always look for something. You always, either when you do an investigation, you're always trying to confirm a presence of a certain condition, or you're trying to exclude other stuff. So with FBC, you're trying to see if there's any infection, if there's any anemia. Obviously, infection, you will have high CRP, you'll have high white blood cell count. With anemia, we'll have low hemoglobin, which these are considered risk factors for acute limb ischemia. It could exacerbate a pre-existing condition that then leads to acute limb ischemia. In terms of use and ease, very important. So it evaluates the renal function. And I want to really leave it just as that. I'm going to talk about it just, I think, in the next slide. Why would we need to evaluate the renal function? So you could already, you can, if you want, you can think about it in the back of your head now, because we'll go back to it. Obviously, also need to use an ease. Obviously, you need to look at the electrolytes as well, because electrolytes could cause arrhythmias, and arrhythmias could, like if atrial fibrillation could lead to embolism. Embolism is the most common cause of acute limb ischemia. You can already tell now. If you're doing things like this, you will be able to tell, okay, what's the cause of acute limb ischemia? Even if you're certain about acute limb ischemia, what's the that it is like acute limb ischemia. You want to know what the cause is. You want to know which artery is affected, etc. So the third thing that you could do is blood grouping and saving. Very important. It makes you quite a very organized doctor. Now you know that what the patient's blood type is and everything, so that if you want to do some kind of blood transfusion or any surgical intervention, you already know what the blood type is, and you kind of just move on straight away. You kind of get on with it. Protein profile, quite obvious one. So if you have a problem with your coagulation pathway, coagulopathy, that's the way they refer to as, it could obviously lead to acute limb ischemia, because acute limb ischemia does happen. One of the biggest causes is thrombosis, and so coagulopathy will exacerbate things like thrombosis, things like hemophilia and thrombophilia, and so many other stuff. There's a lot of blood disorders that could lead to someone being in a hypercoagulable state. You have to do an ECG. Can somebody tell me why you do an ECG? I just want to talk on you for everything. So why is it a good idea to do an ECG? Somebody has a pain in the right leg. Why would you need to scan the heart? Anyone? Acute DVT. Okay, you mean DVT? That's a really good thought. I didn't even think of it. DVT could cause PE, which leads to sinus tachycardia, which is seen in the ECG. Very good, very good. There is another one, but this is a very good one. I didn't even think of it. There's another reason why you might need to do an ECG. If I only give you a hint, think about the most common cause of acute limb ischemia that I've mentioned, and then the most common thing that lead to this cause that then obviously lead to acute limb ischemia. Very good. Check for atrial fibrillation. This is diagnostic straight away. You see there is irregular all waves intervals. So the all wave intervals are irregular, and the irregularity is also irregular, and there is no P wave. Boom, atrial fibrillation. You're all certain now that this is acute limb ischemia due to atrial fibrillation. You've already tied the condition just by doing ECG. So obviously it's very important. Oh, sorry, Sorry about that. Okay. So now we've done the initial routine investigations, like the majority of them are bedside ones. Now we're gonna move to imaging. Imaging, obviously, one of them will be one will be like the kind of the definitive diagnostic thing that the investigation that you do to be like, okay, this is 100% acute limb ischemia. So the first thing that we do is Doppler ultrasound. It always gets mentioned. It's non-invasive. It's quick. It's simple. It always gets mentioned. So it's true. It's these things. It's quick. It's non-invasive. It's simple, and it very quickly assesses the blood flow to the affected limb. Very quickly, you could already tell, okay, this is what's going on now. You can carry on with your kind of management just based on Doppler ultrasound. It's quite a powerful imaging. However, it does obviously all the books mention that it's operator dependent. You have to have someone who can use it and diagnose from it. And then if we now move on to a more advanced one that is less readily available, one that is more expensive, one that you can't use it every single patient, you have to be kind of, okay, this is probably acute limb ischemia. Let me do the CT angiography. So CT angiography is also very important. The reason why it's important, one of the biggest reasons, obviously, it confirms that this is acute limb ischemia, but also it tells us if this leg is salvageable or not. Whether you can save this leg or not, because it tells you how where about the blockage is, where are we meant to kind of surgically intervene, and it tells you like, as you can see in the picture, how high the occlusion is. And so it obviously provide a detailed anatomical side of the occlusion. That's what I've mentioned. And it's quite important in decision making in terms of surgical interventions. You can't really base your surgical intervention pre-planning decision making based on Doppler ultrasound. Right. So this is in terms of investigations. With so many other conditions, there is some sort of a staging for acute limb ischemia. And it makes sense why would you have such staging. It's because I told you it could lead to potential amputation. It might not lead to it. It might. We don't know. So there has to be some sort of staging. So we can kind of be like, okay, this limb could be saved, or be like, okay, no, it's probably irreversible. We just need to cut the limb off. This is just the management. And so the classification that we're going to talk about is called the Rutherford classification. So stage 1 is viable limb. It's just as simple as that. I'm just making it as simple as possible. The limb is still viable. The Doppler sound shows some sort of arterial signal. It's not that bad, basically. It's not that bad. This is stage 1. And then there is stage 2A, 2B, and stage 3. Don't ask me why they haven't just said it 1, 2, 3, 4, but there's just a way it is. 1, 2A, 2B, 3. I guess the reason why they did it is because 3, if I could just jump ahead, 3 is when it's just irreversible, just as simple as that. It's irreversible damage, necrosis, gangrene, whatever you want to call it. It's non-viable. You're just gonna have to amputate it. So it kind of makes sense. One of them is viable. You could see an arterial sound. This is, by the way, how I kind of learn staging as well. I learn the good one, the very good one, and the very bad one, and then the ones in the middle is kind of the middle. You can kind of guess them yourself sometimes. So the worst one is stage 3, where you have to amputate it, and then you've got stage 2, which has some sort of mild sensory deficit, but it has no motor deficit. And so if you go back to the clinical presentation, the 6 Ps, the last one out of the 6 Ps was paralysis. If there are paralysis, that means there is motor deficit. That already tells you it cannot be stage 1 or stage 2. It has to be at least stage 2B, if not stage 3. So the classification further tells you that time is very critical with acute limb ischemia. Okay. So when I said we need to check for the use and ease, that's because we need to check for the renal function. I'll be very impressed if somebody get this one. But why do we need to check for the renal function? Obviously, that's not something you're gonna do straight away. In medicine, generally, you try to tackle what's gonna most likely to kill the patient. Having some sort of a renal problem is not gonna kill the patient. Acute limb ischemia definitely can. So why do we, maybe later on, after we already started the management of acute limb ischemia, why do we need to check for the renal function? Okay, good one. Yeah, this is not the one I'm thinking of, but it's always very good to say that as well. Actually, I've mentioned this, that U's and E's always get done also because you see, if you already have a pre-existing CKD, already have an AKI due to dehydration, and see if the meds that we're trying to, because some of the anticoagulant, the meds give for coagulation anticoagulants, some of them are nephrotoxic, which is obviously you can already kind of imagine that some of the management will be anticoagulants. Yeah, good point. The one that is kind of a fancy reason is because it can lead to AKI, and that's because the muscle cells, when they get damaged, they release myoglobin, which leads to myoglobinuria, which is just myoglobin in the urine, which can cause AKI. It can cause what we call fake hematuria or pseudo hematuria, where the urine might look a little bit bloodish or look a bit reddish, but it's not actually blood, it's just the myoglobin. So this is kind of the fancy reason, but Aisha, this is a very good point, that you also need to do that for the meds too. Very good. Okay. So I think I've mentioned this one already, so I just want to make sure everybody's following. What is the most definitive investigation for acute limb ischemia? Okay. So by the way, this is a very what's the word? Very common exam question. They could give you a clinical picture of acute limb ischemia, then tell you, based on the most likely diagnosis, what's the most definitive investigation for this condition. So the answer is CT angio. It's not Doppler ultrasound. So the Doppler ultrasound would be the answer if the question was, what is the most useful initial imaging that could happen with the acute limb ischemia? It's not definitive. You cannot see everything that's happening in acute limb ischemia. You cannot tell how big the occlusion is. You can't tell exactly where the occlusion is or how bad is it really without a CT angiography. However, Doppler ultrasound, due to its high availability compared to CT angio and how cheap it is, and as I said, simple and non-invasive, it's the best initial investigation. ECG is something that you could be done. Obviously, I've already mentioned you could do it for AF. You could do it to check for PE, which would happen as a result of a DVT, like Yusuf mentioned, and you can do all sorts of blood tests that we've mentioned as well. Okay. So management. So I think I'll try to be more quick now because I'm running a little bit of time. But with any condition, we do ABCDE approach, which is, just to make it quite very simple, it's just a way to tackle what's most likely to kill the patient first, which is airway, breathing, circulation, etc., etc. So airway is more likely to kill the patient than breathing would, and then breathing more likely would kill the patient before circulation does. Circulation obviously involves things like what acute limb ischemia does and things like hypotension and whatnot. So never forget A to E assessment. And in the exam, if it tells you what is the best initial management to be done, and one of the options is A to E assessment, I can tell you now confidently it is A to E assessment. This is the correct answer. But now we're actually treating, now if we want to manage the actual acute limb ischemia now we've made sure the airway, breathing, etc., this is not going to kill the patient. You have to remember what the patient came with. The more 100%, they're coming with pain. This is the most common symptom, and it's the one that disturbs the patient the most. And so we want to give them some kind of analgesia. So obviously, make sure they're not on opioids first, and nothing's going on really. They don't have any problems with taking opioids. But then you try to give them some IV opioids just for the pain control, and then you would like to give them IV heparin to prevent the thrombus from being worse. Just so you guys know what's going on now, we're talking about the acute management of acute limb ischemia. This is what you do kind of straight away once we're like, okay, this is acute limb ischemia. All right, let me give analgesia. I'm gonna give some opioids for the pain. I'm gonna give some IV heparin, which has a fast onset to prevent thrombus propagation, just thrombus from being worse. And then I'm gonna straight away give a vascular referral to the consultant, to the surgeons, to come and have their own opinion, because they're the one who's gonna give the definitive management. So now the question is, what is the definitive management? Unfortunately, it's not a very quick, straightforward answer. It depends what's going on. So if it's a thrombotic cause, embolic cause, or the different scenario is if it's a non-viable limb. And so if it is thrombotic cause, you further divide it into whether it's complete ischemia or incomplete ischemia. Okay, so the incomplete ischemia just means if the artery is not yet completely blocked. Eventually it will get blocked. That's why it eventually leads to amputation. But if it's incomplete, then we'll do some kind of an endovascular procedure. So the first one that we could do that it doesn't that we do in so many other conditions as well is angioplasty. So we get a balloon and then we inflate it, and then as you can see in the top picture, and then it opens the artery up. Very simple. Obviously, you don't need to know how it's actually done. You're not a surgeon yet, but the idea of it is very simple. You just need to open the artery up using some kind of a stent, which you open the stent by expanding a balloon inside the stent. Second one is thrombectomy. As the name suggests, you just break the you physically break the thrombus, and so the artery could get revascularized. Third one is the intra-arterial thrombolysis, and you would do it using a clot dissolving drug. Does anybody know what the drug is? I'm not going to try to ask many more questions because we're running out of time, but I'm be interested to know if anybody knows what the drug we would give intra-arterially. So you'd give it for the artery that you know it's occluded. You give that drug, and then that drug does dissolve the clot. Okay, I know it's quite a tough question. So one of the most common drug that's given is called altiplase. Altiplase, yeah, that's what he said. Yeah, altiplase. I believe it's the mechanism of action is something got to do with plasminogen and plasmin, which I do not remember how it's involved in the entire extrinsic and intrinsic pathway of the coagulation, all that stuff. But it is involved, and it's quite an important factor in this entire cycle. So it blocks that. If it's complete ischemia, you do an urgent bypass surgery. Very simple. Bypass, it just means you're gonna put some sort of a structure to connect before the blockage and after the blockage. You leave the blockage in its place. You kind of make an artificial collateral circulation yourself, just like that, and then it bypass it, and then it carry on, and it reperfuse the rest of the limb. Right. If it's an embolic cause, then there is two different things you could do. So you could do embolectomy using something called Fogarty catheter, or you can do untable thrombolysis. So the untable thrombolysis, I don't know much about, but I know it's just it's a standard procedure where you use and a standard angiography catheter, and it is used to so the surgery. It's obviously a surgical procedure, and it's used to redirect a thrombolytic agent into this clot inside of it, so it kind of dissolves the clot. It's quite similar to the altiplase kind of thing. In terms of embolectomy, I had a video about, but just for the interest of time, it's like a 10-second video, but just for the interest of time, I'm going to skip it. But you basically enter this catheter in, and it's quite simple in terms of just how it works, the mechanism of it. You go all the way, you pick the clot up, and then you bring it back with you. And then you come out with the catheter with the clot at the end of it. It's very simple. You just literally go in there, get that bad boy out of it, and then the artery gets reperfused. If it's non-viable limb, which is what we don't want, this is what the entire lecture is about, we just do amputation. So all of these were acute management. Now we move on to more of long-term management. So you've long-term management, you've got obviously things like close monitoring that you have to do straight after the surgery, to things like physical examination. So checking for the pulses that we've talked about, doing Doppler ultrasound to check that the reperfusion is still there and it hasn't re-occluded, because that could happen. Obviously, wound care, there's a lot of conditions that could happen if the wound is not closed properly, if it's opened, if it gets infected. So with any surgery, you have to do some sort of wound care after the surgery. And then using the Doppler ultrasound, you'd assess for the bypass patency to make sure there hasn't been any re-occlusion going on. In terms of pain management, obviously we've started, if you remember, we started IV opioids. Now we're going to taper it down. Taper it down just means bringing it down a little bit, maybe in terms of the dosage, in terms of how many times we're giving it. And eventually, now that everything is revascularized as well, it shouldn't be as painful. We'd go to non-opioid kind of route, and maybe the NSAIDs is enough, given that the kidneys should be enough for them just to that's going on, they can kind of take care of that. you have to make sense. You have to give some sort of antithrombotic therapy. So things like aspirin, clopidogrel. This is kind of antiplatelet therapy. In terms of anticoagulation, you give something like heparin, warfarin. Obviously, with warfarin, you have to repeatedly check the INR of the patient to make sure it's within the target INR. And then after all that, obviously you have to think about the patient as a person, not just as a medical condition. So you have to do some sort of rehabilitation to make sure they go to as much functional capacity as you can possibly can with this patient. And if it means going back to fully normal again. So this is the long-term management. Complications, we've already spoken about the compartment syndrome, which happens because there is some sort of increased intra-compartmental pressure. So it's just a muscle compartment. So every muscle fibers, there's few of them in one compartment. And if one compartment has high pressure, that could lead to compartment syndrome, which causes what we call the disproportionate pain. And it requires urgent fasciotomy to relieve the pressure. So that it's just there is a fascia that's surrounding the compartment. You simply cut the fascia a little bit so the pressure could get a little bit released. It's quite simple. The idea or the reason behind the idea behind the treatment is quite simple. You just cut a little bit so the pressure could go off. Mortality is quite high. Sepsis could happen. Sepsis could happen from maybe the wound getting infected, and then from the wound, the bacteria goes into the blood and eventually goes in sepsis. Multi-system organ failure, if maybe some of the organs doesn't get reperfused as quickly, and which obviously requires retreatment. It could, and then the one of the complications that it could lead to some sort of cardiovascular events later on, because you already know that patient is in some sort of hypercoagulable state, some sort of maybe AF that can cause embolism, that can cause strokes later on in life. So in terms of this, so this is one of the complications. The second one would be recurrent ischemia. So as I said, it could get re-occluded. If you think about it, the risk factors are still there. We still really haven't tackled the risk factors. Age is a risk factor. You can't really change. High cholesterol is a risk factor. You can obviously give statins and stuff for cholesterol, but the risk is still there somehow. And so and even just the idea that the acute limb ischemia has happened, that means there is a higher chance that acute limb ischemia happening again. Obviously, not the biggest, but one of the most common complications is amputation. This is what we're trying to kind of avoid. So the last one, what do you think the most common level of amputation that happens for severe acute limb ischemia? To think about it, you don't even need to think about it in a logical point of view. I mean, not in a medical point of view, just in a logical point of view. What do you think? Which one? Okay. So we got 50-50 for below knee and above knee. So it's below knee. And the reason behind it is quite simple. It's just because you want to preserve the knee joint as much as possible. And majority of the time, even if you need to amputate some like a place in a portion of the limb, you can majority of the time preserve the knee. Anything that's artificial is worse than what you're born with. That's just a general rule in medicine. So we're trying to avoid knee and not give, because obviously a prosthetic limb with a existing normal knee is much easier to deal with. In terms of the patient, much easier for them to deal with. So these are the different types of amputations. You've got below knee amputation, you've got an above knee amputation. In terms of which one do you use, it just depends how bad the ischemia is and how necrotic the tissue went and how superiorly the necrotic tissues went up. And you would, and based on that, you would just decide whether it's below or above knee amputation. Transfemoral amputation is just when it goes right through the femoral. It's a type of above knee amputation. There's obviously a lot of other different types of amputations, but these are just kind of the general ones. Just to end it, there's something called the phantom limb pain that I wanted to speak about very quickly. So it's just this, I think a lot of people know it already, but it's just a sensory perception of pain in a limb that already got amputated. And so this is another complication that could happen to the patient. So you could see how big acute limb ischemia is. And it doesn't really have, because we don't know exactly why it happens, it doesn't really have a direct treatment. It's just more of medication, stimulation therapies, and psychological support. And that's it. So this is a summary. I think it includes the very big points about acute limb ischemia. So if you guys want to screenshot it or something and put it in your notes, it's quite good to look at before the exam. And that's it. Thank you very much for sticking that long. That session did take a little bit more than expected. So thank you for the people who survived that long. And yeah, I'll pass it along to Hank.
Thank you so much for that incredible presentation. So I will just now put the feedback form in the chat. It should be on there. If you guys fill it out, you can have access to the certificate. What I'll also do is I'm just going to post the link to the Geeky Medics raffle. So if you fill this out, you will be able to access the Geeky Medics surgical flashcards or Geeky Medics OSCE stations if you are lucky enough to get randomly selected. So yeah, once again, thank you so much. And if you follow our social medias, I put in the chat, you can keep up to date with the next sessions that are going on and any other resources that we will be sending out. So thank you so much, Saib. Any other questions, put them in the chat as well.
Thank you very much, guys, for sticking out for being here for 1 hour 20 minutes. Any questions?
I've put the link to the form for the chance to win free access to the surgical flashcards and OSCE stations. I'll just put the code as well.
Yeah, no problem. No problem. Just give me a second to get the slide. I think it was slide 14, maybe. 1 second. I'll be impressed if it's actually slide 14. Oh, it's not 14. Slide 13. I think, or 12, 13. Yeah, so to run through them back again. So the popliteal artery, as I've mentioned, is obviously we're looking at posterior point of in the posterior side, and it runs from the popliteal fossa. So when the femoral artery, which is in the anterior side, it goes through the muscles and then it pops out from the other side. So now we're looking from the back. We're looking at the right leg from the posterior view, such as know what I'm talking about. And then the posterior artery goes down inferiorly, and then it gives the first branch, which is the anterior tibial branch, anterior tibial artery. And then you might be wondering, it's called the anterior tibial artery. Why is it called anterior if we're looking at the posterior point side? It's because the moment the artery gets branched, it goes through the muscles and then pops out from the other side. So now look at the image on the right. as you can see, it popped out from the other side, and now it's on the anterior side. That's why it's called the anterior tibial artery. And then it goes down, it supplies all the muscles that you can see around it, so the anterior compartment. And then once it crosses this fascia right there, which is called the superior extensor retiniculum, it becomes the dorsalis pedis artery. So dorsalis pedis artery is obviously one of the pulses that you feel for. And just a little point about the dorsalis pedis artery. When I've mentioned that it's right next to the extensor hallucis longus, as you can see, the tendon is right there. This is the tendon I'm talking about. And obviously it's connecting to a muscle, and this is the muscle of the tendon I'm talking about. And then the artery is just right lateral to it. So it makes sense that this is where you would feel for the pulse. If we go back now, we go into popliteal artery, we're going down to the anterior tibial artery. Because there is an anterior, you can already guess there is a posterior tibial artery. And this is in fact the second pulse that you'd feel for in the feet. So it goes down, down, down. We're just following it along, and now it's in the posterior view, in the posterior side of the medial malleolus. So the medial malleolus is just this bony-like structure, the projection of the tibia, and just right posterior to it is the posterior tibial artery. And so it makes now again, it also makes sense why you'd feel for the pulse of the posterior tibial artery in this place. If we now go back, we've said there is a tibial artery, there's a tibial artery, the big brother, the big bone of the tibia. Now it has two arteries. The fibula is feeling a little bit jealous, is feeling a bit left out. Why does it not have a branch? So it does have a branch, but then the dad, the popliteal artery, as being the dad, is just he has a son that he likes more, which is the tibial artery. So he hasn't given any branches to the fibular artery. It's in fact the posterior tibial artery that gives branch to the fibular artery. So this is an important point. The fibular artery is not a direct branch of the popliteal artery. It's only the anterior and the posterior tibial arteries that are the biggest two branches of the popliteal artery, and that's it. Obviously, there's a small branch as well. But the fibular artery is a branch of the posterior tibial artery, which runs on the lateral side. It supplies all the muscles on the lateral side, and it then eventually obviously form some kind of anastomosis with the posterior tibial artery. So it's just a kind of a run through. Just let me know if anything doesn't make sense.
The code should be on the chat now, and the next session that we have is on upper GI surgery on the 10th of March. Put any questions in the chat for to be answered. But otherwise, thank you so much for attending, and we hope to see you soon.